So anyways, let's go. Let's go. Just part of disclosures, I am a clinical investigator for HPV-related trials. I get a very a part of my salary from Merck, but I need to tell the audience that. So what I plan to do in the next 45, 50 minutes is really just kind of review some of the clinical trial data about the HPV vaccine. And I know we're in a blended audience, so I'll speak a little bit about what HPV is first. But the most of my talk is going to address media concerns about the vaccine and the scientific evidence that we have that surrounds these concerns. And finally, intermixed in some of this is some of the clinical updates I have about the vaccine. For those of you who are not familiar with HPV, it's a DNA virus. And right now we have defined over 150 types, and types are defined as a new type if they have less than 80% homology with previous types. I've been primarily interested in those 40 types that kind of stick around in the genital tract. We divide types based on their oncogenic potential. So there are high-risk types, meaning they have the potential to progress onto cancer. And we have low-risk types that do cause clinical disease, but don't by themselves create cancer. However, the good news is, even though we know a lot of women and men will become infected with HPV, and we have data from Indiana that shows that adolescent teenagers, when you frequently sample them, we have found that 100% of them have HPV at one time or another. They're mostly sexually transmitted, but the good news is most of them do not create any clinical manifestations. However, with the help of Dr. Zerhausen in the 1970s, what we've discovered is that this virus is responsible for causing cancer, primarily cervical cancer. And what we know is the virus in itself, by itself, will not cause cancer, but that persistence, along with other factors, will progress to cancer. I do STD talks all the time in medical school, and our joke is, what is a talk without pictures? So I had to bring one with me today. But I think it nicely demonstrates some of the diseases we see with HPV. And at the top and to your left, you can see low-risk types, primarily 6 and 11, are responsible for 90% of the genital warts, which we see on this penis. But for some of you who may not do pediatrics, HPV 6 and 11 can cause a laryngeal papillomatosis, which can be warts on the larynx. They're very obstructive. And for some young children, this requires a lot of lasering and actually tracheostomy. So significant morbidity, but we don't see it as a frequent flyer. What we have, as women, should be particularly interested in is type 16 and 18. And 16 and 18 are responsible and found in about 70% of cervical cancers. HPV is one of those viruses that actually has been associated with about 5% of all cancers in the world. That's greater than any infectious agent that we are aware of. And what you can see is that primarily we find HPV, given our molecular techniques, in probably close to 100% of cervical cancers. And what we're discovering likewise in the anal canal is that it's associated with a lot of anal cancers there too. And there's a lot of similarities, believe it or not, between the cervix mucosa and the anal mucosa, and that's probably why. Having said that, it's associated with a lot of other genital female cancers, including vaginal and vulvar. It's associated with penile cancer. And what has come into the literature over the last 10 years is association with certain oropharyngeal cancers, primarily in the base of the tongue and the tonsil area. There are HPV-related cancers, and we're seeing a growing rise in that type of cancer. Now, I want to be really clear, in the oral pharynx, there are HPV negative ones, and those tend to be associated with alcohol and cigarette smoking. But those associated with HPV are a different breed, and their risk factors are actually have to do the same with sexually transmitted infections, number of partners, number of frequency of exposure. So what we know from the randomized clinical trials with HPV, that it's highly efficacious at preventing persistent infections, external genital lesions, and precancers in women, and now men aged 15 to 26. The duration of this protection is unabated at a minimum of 8 years. That's meaning that's all we have the data for. And this 8 years actually comes from clinical to phase 2 FDA-approved trials with the vaccine when it was only for HPV 16. What we now have is data 5 and 6 years out from phase 2 and 3 trials with the quadrivalent vaccine and the bivalent vaccine. And there are trials ongoing for the next 14 years to look at duration of protection. I want to be really clear that there's no evidence that the vaccines protect against existing HPV. And I want to point this out because I try to vaccinate women before they become sexually active. But I can't tell you how many times a mother tells me, oh, she doesn't need it, she hasn't had sex. Well, I'm here to tell you mothers are lousy predictors of sexual activity. We know that in the research. And my daughter keeps insisting, oh, I'll tell you. I said, I don't want to hear, I don't want to know. You know what to do if you make that choice. Anyways, the incidence of adverse events are comparable to the placebo with expected background rates of the general population. When we did clinical trials, I think it's important for those of you who don't understand, is we did not wait till women to get cervical cancer. The cutoff or the endpoints of the trial really focused on high-grade intraepithelial lesions. And the reason is for 2 reasons. 3, it's unethical to wait for women to progress to cancer. Nobody would want to do that. Not only is it unethical, but it takes, on the average, 15 to 20 years, and that's too costly to run clinical trials. But what we know is that HPV follows a pretty good continuum in its progression to cervical cancer, that we start out with low-grade lesions, they progress to moderate, severe, and to full thickness, which is considered carcinoma in situ. Having said that, I do want to reiterate again, there's a lot of clearance of HPV. So if one has it, they may even get a mild grade abnormality lesion, but there's a fair amount of regression in the lower the lesion grade as compared to higher lesions that progress on to cancer. One of the clinical updates I might say is, we used to think HPV infections clear. I think what we're beginning to understand from our work and others is that this is probably more of a latent virus, that there are periods of non-detection, but something causes the virus to reactivate. And so we especially understood this with women with HIV. They would be tested for HPV for a prolonged period of time, and then they would not have sex after the diagnosis. But what we found is that we kept seeing different types appear, knowing that they weren't sexually active. And we're finding this in our adolescents. We follow them for a while, and they have periods of non-detection, and some of them have periods of redetection. And data suggests this isn't really, they're becoming infected with a new subtype, that this really is the same HPV that they had earlier. So the HPV trials really have demonstrated efficacy, and when we look at the per protocol efficacy, and per protocol efficacy means these women got, and the men got they got the 3 shots in the 6 months. They were HPV negative by serology and DNA testing for a specific type at the beginning of the trial and 1 month after they completed the vaccine. And what we found is the bivalent vaccine, which protects against types 16 and 18, was 93 to 95% efficacious at preventing persistent disease and precancers. The quadrivalent vaccine, which protects against 16 and 18 and type 6 and 11, was 99% efficacious in preventing cervical, vaginal, and vulvar diseases, 100% in women in preventing genital warts, 90% efficacious in preventing warts in males, and 75% efficacious in preventing anal cancers in men. I would say the anal cancer data primarily came from a subgroup within the men's clinical trial. It was a group of men having sex with men, but there's such a high incidence of anal precancers in that group that it was easy to conduct and get the evidence from that. What I find amazing, and I still counter this in Indiana from parent groups sometimes, is that despite the safety and the efficacy that's been published, and despite our clinical experience now at 8 years, and despite the fact that this vaccine probably has the greatest proof that it is efficacious, it still continues to be highly scrutinized by the public and the media. I think part of the reason it gets scrutinized is there was a tremendous campaign by the drug companies to get the vaccine out. And that was done in part, they knew they were fighting a vaccine because that was there to prevent sexually transmitted infections. And people are sometimes uncomfortable with that. But remember, we get a lot of work in our partnerships with drug companies, and despite there has been some bad outcomes that people get the perceptions that the drug companies are paying investigators off, and they're going to just give us poor data. And unfortunately, there's been a few cases that have been the loudest and the most vocal and have gave the public and some physicians that opinion. Having said that, the media has had a heyday. This is from a colleague in Canada at McMaster's, and what you can see, this is from the McLean magazine. The editors took some things out of content and highlighted them. And you can see they were worried about our daughters being guinea pigs. There's too many unknowns. I like this one. It's easy as a parent to get your child a vaccine than say condoms reduce HPV. For us who work with HPV and work with teenagers, I can tell you condoms probably do reduce some HPV, but they're not very efficacious. The other thing is they really latched on to the side effects, and as all of us know, every drug has side effects, but we'll talk about that more. Then what they did is wrote this statement: imperfect compliance, such as getting all the doses and prior exposure to HPV, could lower the 70% protection rate down to 17%. They did this by taking that small group of people that have been sexually active and got the vaccine late in life. So they've taken what is generally quoted as the vaccine being 70 to 80% efficacious in general populations down to 17. It doesn't help the reputation. This was on CNN. Girls and women have blamed the vaccine for causing ailments from nausea to paralysis, even death. Oprah Winfrey's medical expert said this: when one woman asked about the HPV vaccine, She advised against getting the shot. I'm a little against my own profession, she says. My own profession feels that everyone should be vaccinated. There have been some deaths from the vaccine. What she suggested was I put my money in getting everybody on a dietary program that would enhance immunity. Doesn't that make you feel good? Tell me about the data when people are well, what they can take to enhance their immunity. Okay, so what do we know? Where do we get the safety data? Well, of course, we get data from the pre-licensure trials. And, you know, as I said, everybody has the right to be skeptical about that. But we have post-licensure trials and evaluation systems that were put into place to specifically look at products, and in this case, vaccines, after they've been marketed. There is a passive system called VAERS, the Vaccine Adverse Events Reporting System, and there's a more active system that was developed in the 90s to address some of the shortcomings of the VAERS system. For those of you who are not familiar with VAERS, we're actually mandated by a law that was drawn up in the 1980s as clinicians to report adverse events. And this was developed by the CDC and the FDA as this system that you could call into and report adverse events based on the timing of the vaccine and the events you want to report. However, it's passive. Nobody's mandated to do it, and that contributes to some of the shortcomings. However, there's a lot of benefits. It monitors for adverse events that were identified early, but it also has the ability to detect signals for unrecognized adverse events as they may pop up. So maybe we give the vaccine, but it's 5 years later that we start to see something happen. This system is developed for reports that will recognize that. It doesn't mean it's causal, but it is hypothesizing, and it requires further investigation. The limitations are great. There's a lot of biases who end up reporting. As I said, not everybody reports. And then there's a lot of incomplete data that comes. There's no denominator, and therefore we can't really look at true rates. But it was not designed to suggest causality. Remember, it's hypothesizing. When we look at VAERS reports for the HPV vaccine, JAMA published this second column from June 2006 to December 2008. There were over 23 million doses at that time distributed. Now, doses distributed doesn't exactly mean that many people got it. It's estimated, well, we know it was about 30,000 young women and men that got the vaccine. There was a total of 12,500 reports approximately, and you can see that the specified adverse events that were assessed, I won't go through them all, but they included syncope, neurological events, autoimmune, and pregnancy-related events and deaths. And they found that the safety profile was consistent with the pre-licensure data, with the exception that they found more venous thrombotic events, and they clearly found more syncope. And I'm going to discuss that. The venous thrombotic events, they hypothesized in this paper that some of the syncope came from the fact that we are now vaccinating young women not only with HPV, they're getting a meningococcal vaccine, they're getting a DTaP vaccine. Our women are getting hepatitis A and whatever other catch-up vaccines that may be involved. And if they come in during flu season, then we're vaccinating them then. The other thing with venous thrombotic events, you can imagine we're immunizing a group of women that are getting reproductive health, and they're also on other things like contraception that may put them at risk. But still, this needs to be explored. They recently updated the VAERS summary, and you can see that on the right, your right-hand column. It's from June 2006 to September 15th of 2011. Again, they found no specific adverse events that they thought were abnormally high, and no clinical patterns were identified. When we look at the VAERS reports, you can see that most of these reports come from females. The female and male column do not jive to be 100% because this is one of the things that happens. Sometimes we don't report the sex when we're reporting to VAERS. There were 71 fatal events, and I'll talk about these a little bit more. Again, the majority from women. The most serious and non-serious events tend to be related to syncope, headaches, and dizziness. But serious, so you know, is defined as either resulting in death, life-threatening illness, hospitalization, or prolonged hospitalization. Most of these reports are provided by the manufacturers, but 40% come from the public. A lot of the times these events were actually 3/4 of the times associated with just the HPV-4 vaccine, and a lot of them occurred the same day of the vaccination. When we look at the serious adverse events, syncope, serious syncope, meaning it resulted in a mandible fracture, a teeth fracture, a hemorrhage of some type, occurred in 202 patients. Because of this, the manufacturer has gone back and really said that women need to be watched for 15 minutes after they receive the vaccination. They had 43 anaphylaxis reports, but I will tell you they could only confirm 20 when they went back and followed these up. There were 71 deaths, as I told you, but again, only 34 of those could actually be verified when they went back and traced. The mean age was 17. There was a range, but the median interval from the vaccine to the outcome was 15 days. And you can see the classification of neurological, pulmonary embolism, infectious, or undetermined. But again, they volunteered that there is no pattern in verified deaths surrounding this. So what they're saying is these expected deaths, the rates, were not out of proportion to what we see in the general community of this age group of people. The rapid cycle analysis is another post-surveillance testing system for vaccines. And again, this was to improve upon the VAERS data. It's a collaboration between the CDC and 10 large managed care organizations throughout the United States. And they actually have the ability to monitor about 3% of the population. They're using electronic medical records, and this is all retrospective. And the events, they're looking at the general safety, pregnancy outcomes, and these neurological thrombotic events that we've been discussing. It really is built there to test specific hypothesis-defined outcomes that we've discussed earlier. But they look at it weekly. And they're doing this weekly to see if the rates change or if anything is being flagged as serious. It is not considered, if something pops out, it warrants further investigation. But again, it's a way of tracking things at a closer look with frequent looks to look at potential associations of the vaccine and outcomes. So far, the rapid cycle analysis, just quickly, has not confirmed any significant risk for the pre-specified adverse events that you see on the screen. However, they did find a slight association between the quadrivalent vaccine and venous thrombotic events. Having said that, it was not statistically significant, but what they have done now is gone back to all the confirmed cases. And at this point, what they find is all the confirmed cases had other risk factors for VTEs. There was no increased rate of anaphylaxis in this study group. The other thing that is happening is there are safety surveillance. Okay, we'll see. The safety surveillance data actually comes out from Kaiser Permanente with the manufacturer, and they're looking at general safety pregnancy outcomes. They have over 200,000 women that they can assess who received at least one dose of the vaccine between the time period of 2006 and 2008. At this point, general safety looks good, except that they do find syncope. There's been some concern, slightly elevated infection rates at the site of injection, but when they went back and looked at that, a lot of this was just, it wasn't true infection, it was just a reaction, a localized reaction to the vaccine. There's been no data to suggest that this is teratogenic or leads to miscarriages, which they're looking at closely. And there really has been no evidence of neurological, rheumatological, autoimmune conditions, with the exceptions that they found a slightly elevated risk of Hashimoto's disease in this group. When they combine the Hashimoto's with the Graves', since they're very similar, they really, this goes away, but there's further investigation. And you can, that information can be referenced, seen in the reference I gave with this slide. Institute of Medicine has also looked at the safety of vaccines. The Institute of Medicine does this for HRSA because HRSA has to define whether a vaccine has been associated with a poor outcome in which somebody is filing suit. So the Institute of Medicine looks at all the data, both locally in the United States and nationally, and assigns causality based on four categories. Either it's convincing, that supports a causal relationship, favors acceptance as a causal relationship, favors rejection, or inadequate to accept or reject a causal relationship. With the HPV vaccine, they clearly felt that syncope was clearly related, not due to the vaccine itself, more may be related to the pain associated with it, and that anaphylaxis favored an acceptance of a causal relationship, but there was no epidemiological evidence to really support or reject an association with the other adverse events. Okay, so second controversy. Everybody thinks if we give a shot for a sexually transmitted infection, that's going to change women's sexual behaviors. Well, we call this risk disinhibition, and it comes from a theory on risk compensation. This theory suggests that most individuals assume a certain level of risk, and if you do something to reduce that level, then they compensate by doing something else that brings that level of risk back to their baseline. This was nicely, they tried to apply this to safety belts. You know, if we put safety belts on, then every motorist is going to go out and drive faster. But the truth is we didn't find that. But I think it does help explain limited effects of an intervention that on more extensive public health problems. The problem I have with the theory is that it implies in some ways that HPV infections have led adolescents to delay intercourse, and we know from studies adolescents aren't that knowledgeable about HPV. What is the evidence for behavioral disinhibition? When we look at non-related trials, when you look at contraceptions brought into the school, condom programs brought into the school, and general sexual education, what we find is that it does not change behaviors. However, in certain clinical phase 2 trials with the HIV vaccine and some of the heart-related interventions, we have found even though people are informed that they may be receiving a placebo, we have seen that there can be certain changes within subgroups of those populations. We don't have any behavior data with regards to the HPV vaccine, but we have a lot of published data about vaccine attitudes and beliefs. And what we find is that only a minority of parents and adolescents truly believe that their daughter or they themselves will change behaviors once they get this vaccine. There was one study that documented a higher belief among low-income minority adolescents, but recent data has really reconfirmed that adolescents just don't think that way. We in Indianapolis have submitted a paper trying to look specifically at this issue, and I'm going to try to walk you through this slide pretty quickly. We had an ongoing longitudinal observation study of risk and behavior factors for sexually transmitted infections that went for 9 years. And these people at enrollment and every 3 months actually had interviews about their sexual behaviors and did a vaginal self-swab that was tested for STIs, including HPV. In 2010, we went back to the same clinics and we recruited 75 girls, used the same questionnaire, and have them perform vaginal swabs. We used matched cohort design, so for every new young lady that was recruited, we matched her to 2 of the historic women in that historical cohort based on their age, whether they were sexually active at time and enrollment, and from the clinic site. And then we compared those 2 groups to see if behaviors changed or if STI rates changed. And I will tell you, in the prospective cohort, 59% of the women had received 2 or more vaccines. I think it was about 60 that had received, out of the 75, had at least received 1 dose. And this is a busy slide, but all I'm going to tell you, there were no differences in behaviors. In fact, we found in the newer cohort that they had more condom-protected events. There were no increased rates of STIs. The only thing that we did find, a reduction in HPV 6, 11, 16, and 18. No-brainer. Okay. I've also heard the third myth out there: it's too costly. We can't afford it. You know, we have great Pap smear tests. Well, these are the statistics where it's true. Pap smear screening has done a wonderful job and has reduced the #1 cancer and killer of women in the United States. This cervical cancer is now number 13. And you can see the statistics. I keep wanting to remind us, particularly a group of women, that this still, cervical cancer in third world countries, is a big deal. It's the 2nd most common cancer among women worldwide. It counts for 86% of cancers in developing countries, and it involves 13% of females. Oops. This terrible? Huh. Just advance the slide. I did.
Just tap anywhere on the slide.
Who would have ever guessed I was so computer illiterate? Okay. I do not want to knock Pap smear screening. I'm talking to a group of women. I think it's been great. But remember, there's some certain limitations. First of all, from a public health standpoint, it's secondary intervention, meaning we are detecting it after disease develops. We know that with a single test, sensitivity isn't great, and liquid cytology really hasn't improved on the sensitivity. Sensitivity picks up with repetitive screening, and that's why we recommend that women at least get 3 Pap smears in a row before we start to spread them out. There's a lot of abnormalities detected, and I think this is important to remember when we calculate cervical cancer cost. As you can see, in 2004, it was estimated that we spend $300 to $400 million per year just dealing with cervical cancer. We spend a lot more dealing with abnormal pap smears and precursors to the tune of upper limits of $2.3 billion. And for women, we spend a fair amount of money on warts. And if you've ever dealt with warts, it's not fun, especially among women who are immunosuppressed. I can't make them go away. So again, I want to remind you that there are a lot of other cancers that are associated with HPV, and that when we look at female cancers, yes, cervical cancer is the #1 HPV-related cancer, but we are seeing increasing rates in anal cancers, and a lot of these are associated with HPV. In the male world, we are seeing them clearly with anal cancer, and there is a growing rate of oral pharyngeal cancers associated with HPV. So Hugh et al. Looked at the data, and when they looked at non-cervical HPV, which included genital cancers or pharyngeal cancers, anal genital warts, and recurrent respiratory papillomatosis, they found that we spent that year $160 million to $1.6 billion. We spend a lot of money on HPV-related disease. This is another slide, and for time's sake, I'm going to pass it. I'm going to briefly remind you, but I'm going to speak a little bit about this, that in 2009, the CDC gave males a permissive okay for the vaccine, meaning they didn't mandate it for males. And there are several reasons that went into it. And one of the biggest reasons was based on models. And we've been using economic models for centuries to define progression of disease, intervention for disease. But for those of you who have never looked at models, and I don't encourage you to run out and do this because it is not always easy, models make a lot of assumptions. And sometimes the assumptions are true and not. But when you look at the HPV model assumptions, they assume that vaccination coverage for women is going to be extremely high. I'm here to tell you that it isn't. In the United States, and the statistics didn't look very much different in 2010, half the girls are getting at least one dose, and only about a third of the women are actually completing the series. The other thing is they assume that they're going to get the vaccine before they start having sex, and we know once you're exposed that the vaccine does not cause, it has no effect. It's a preventative vaccine. And there's some data to suggest that those at greatest risk for HPV-related disease are not also getting the vaccine, so will it really impact cancer? The other thing that the other assumption is made is that duration of the antibody response may be lifelong. It may be 10 years. It may require a booster. I will tell you, when hepatitis B came out, we were at the same stage. We didn't know about the antibody response, and we know we don't really have to booster these people either. So when you look at the models, most of the models really speak that it's going to be cost effective when we give the vaccine to 11 and 12 years old. And we make these models work better if we give it to women before they have sex. There's less certainty in the models about the cost effectiveness for older women and males. And actually, that's tied to my third point, which female vaccination levels impact policy about male vaccination. That we know when we vaccinate a lot of women, high numbers, that the need for the vaccine may be less in men. Having said that, how do we look at reducing the cost? I think the one thing is we assure that there's high vaccination rate among those that are targeted for the vaccines. The other thing is I will look for simplified schedule. The NCI has produced out of their Costa Rica data that some efficacy data looking at just receiving 2 versus 3 shots. Canada and several other countries are actually looking at extending the cycle, giving 2 doses early, and they're going to examine them 5 years later to see if they really need a 3rd dose. The other thing that I remind is procurement programs do a much better job at advocating for cheaper prices. I was reading in the CDC, Gavi, which is the Global Alliance for Vaccine and Immunization, is now getting this vaccine for $15 a shot, which I will tell you in the private sector, it costs $360 probably for a shot. I think we have to reassure ourselves that prices do decline, and I'm here to advocate getting more companies out there making the vaccine because that will drive the market prices down. And the other thing I remind people, there are 2 manufacturers of the vaccine now. They could not supply the world need today if they needed to. So advocating for others is helpful. Gosh. Okay. So what are some of the updates? ACIP actually made changes in the male recommendations, and now they went from a permissive to a routine vaccination for all 11 and 12-year-old males for 3 doses with the HPV, the quadrivalent vaccines. And they base this that benefits are greater than adverse. There was a high value in preventing male cancers. I hope they feel the same way about females. And that HPV-4 was most likely to be cost effective if all HPV outcomes were included in models, the vaccine cost fell, and female coverage remains low. They continue to recommend at a permissive level vaccination for 13 to 21-year-olds, recommending catch-up. And I know, because I work primarily in VCF clinics, that VCF funds do pay for this, and that it still may be given to males 22 to 26 years old. The last concern I have heard is about type replacement. We know that this vaccine is geared at 4 HPV types, and people are concerned if we drain the pool, will it fill up with other types that cause cancer? And this is based, some of that we did see with the pneumococcal vaccine. But I remind people, pneumococcus is a bacteria, this is a virus. It really has a very slow mutation rate. So experts really don't think it will happen. Part of this is also suggested when we look at epidemiological studies. We see that women can be infected with multiple types at the same time. And when we've gone in and analyzed whether one type does not occur when you have a 16 per se, we find no association. So we really believe that type replacement won't happen. So what don't we know about the vaccine? First of all, we don't know really how long the serological response will last. As I said earlier, we were no further along when we had hepatitis B first coming out. However, there is a Nordic study which will assess women for 14 years in Norwegian countries where they have good medical follow-up and records as women travel. And they've also, Merck has extended one of their adolescent trials. Initially, younger adolescents just were given the vaccine and had their antibodies assessed. But what they're doing now is following these women into the teenage years, and they've seen no breakthrough cases at this point. And they will continue these trials for 10 more years. The other thing is we don't know really what the impact of the vaccine will be on recurrent respiratory papillomatosis, although we keep figuring that in. The same may be true even though we have the data on anal prevention, cancer prevention is mostly coming from men having sex with men. We don't realize what the true impact will be on women, and in men who have sex with women. We don't even really know what happens when we vaccinate men, how much that does protect women, although we have probably pretty good evidence that it may be pretty generous, but we just don't have that exact transmissibility data at a single time point to understand. Finally, we don't know what the vaccine will do in immunosuppressed individuals. I will say that we know immunosuppressed individuals with HIV actually mount a natural immune response to HPV. So I'm not and we have some limited data to suggest that their immune response will be fine. So in conclusion, I think the safety data are amongst the most well-documented for the vaccine. And I feel very strongly that when you hear people say, well, it causes Guillain-Barré, that you have to help people understand the context from which they're taking this information. I think doing nothing has very high cost with regards to morbidity and mortality in HPV-related disease. And although the clinical trials do not look at specific endpoints of cancer, the natural history of HPV infections and cervical disease really indicate that looking at cervical precancers is an acceptable endpoint, not to mention that it is more ethical. And we now have early data out of Australia that really has demonstrated that when they had massive vaccination, 3 years later, they're seeing a marked reduction in genital warts. The first data to really suggest that this has an effect. I want to always be cautious that cervical screening needs to continue, even despite the vaccination. I think screening will change. We will probably start later. We'll spread it out further once the vaccination is underway, but at this time, it needs to continue as currently recommended. I always want to just remind people that from a public health perspective, primary intervention with a vaccine before the disease develops always has resulted in better outcomes than secondary intervention. And then finally, I just want to remind people that vaccination prior to exposure is critical, and that none of us are mind readers of the adolescent brain. And most recent figures say, by age 14, 13% of young women are having sex. By age 19, it's closer to 70%. And we know that HPV acquisition is very high post-first sex. Therefore, I understand and I really encourage vaccination at 11 and 12, despite what we may think about that individual. Finally, I will end by saying to this group of women, a small step for adolescent females, but a large step for womankind. Thank you. Questions?
Oh, my daughter is 28. She's been married for 5 years, and I was surprised that her gynecologist recommended that she be vaccinated against HPV.
I'm a little surprised too. There is data in the older women's study. I call it the more mature women's study, not the older women's study that gets thrown around in Merck. That the further these women get out, the vaccine does have some efficacy as those current cases drop out. So it's not truly contraindicated. I think the biggest issue is the payment. Insurance companies won't pay for it, and so one will be, unfortunately, stuck with a large bill of close to $1,000 for 3 vaccines. Right. Exactly. The more partners, the longer sexual exposure, less efficacy of the vaccine. Yes.
I'm Linda Brodsky from Buffalo. I'm a pediatric otolaryngologist, so I have a fair understanding of human papillomaviruses in the upper airway, in the upper aerodigestive tract. I might suggest that in order to overcome what I see always as the public perception of treating women's diseases is less important than treating male diseases, that we refocus on the fact that human papillomavirus in its latent form is increasingly found in many, many upper aerodigestive tract cancers, which are on the rise.
Yes.
And I think that making it just a sexually transmitted disease is not in our best interests, and to make this as a disease for everyone. And that goes to the second point of the changing sexual patterns of our adolescents or older people, this friends with benefits. And the issue of oral sex and how that's being transmitting it, having somebody who sees these papillomas in the oral cavities of young children who undergo sexual abuse and whatnot. It's of course you have to report those. It's another stage, it's another issue that should be brought forward to public attention, and maybe the people who are on the Oprah show and other places will not just look at it as a woman's issue, again, universalizing this issue, as it should be. And it was an excellent, excellent talk. Thank you.
Thank you. I couldn't agree with you more, and in fact, that's probably the reason I was the loudest advocate for males getting the vaccine. I believe equity, take the gender out of it. The other thing, just in response to your comment, at the International HPV meetings, there was a really cool series of 3. We know it's prophylactic, but they had young children with laryngeal papillomatosis and some older cases, and it was just a case series. But they found that their immune response to HPV was really low in those cases. Not everybody makes a natural serological response. They gave the vaccine to that group. It's just a case series, and they found remarkable regression in those people that did. So even though I would not claim it's a therapeutic vaccine, I was really struck by that piece of information. Yes, ma'am.
I don't know whether I'm first, but I'm Shelley Ross. I'm the Secretary General of the Medical Women's International. But I'm here to sing the praises of the Federation of Medical Women of Canada, because when our MWIA Treasurer, Dr. Gail Beck, was president, she lobbied the government in Canada, and it was the Federation that was actually responsible for getting the in-school program going for HPV. With our current executive, we are now pushing our provincial governments to immunize the boys. We've had quite a lobbying campaign, and I think that the Federation has done a marvelous job in advocacy work here.
Right. That's actually why Australia and places like Canada have had more efficacy in vaccinating women, is because through the schools we have no school-mandated vaccines. And to you, and you probably are aware of the McLean. Yes.
Hi, my name is Veronica. I'm part of Florida International University. I'm a medical student. And I just wanted to know your thoughts on the Choosing Wisely campaign. The American Academy of Family Physicians has recommended not to perform pap smears on women younger than 21. So I just wanted to know your thoughts on that recommendation.
That's a very strong recommendation. Actually, ACOG, the American College of Obstetrics and Gynecology, and the American Cancer Society endorsed those recommendations. And it's really, the pap smear screening changed as we understood HPV epidemiology. I was part of this group. I learned a colposcopy, and we were freezing young women's cervix for minor abnormalities that probably would regress. So what we know from the HPV is that epidemiology, women acquire HPV quite early, but they also, it clears or it goes away, as well as those lesions without intervention. So pap smear screening has changed to reflect the understanding the epidemiology. 21 was chosen because some people are always not comfortable asking whether somebody's had sex or not. And we know cervical cancer is a function of having sex. But it was also reflective that if a woman did get HPV, it persisted and was going to lead to a lesion. At 21, it would be a lesion that is curable if once detected. So I do believe in those recommendations. I strongly endorse them. And getting pap smear earlier is not cost effective.
And just a second comment on that, that's not just cost effective. We know that the most dangerous outcome of all the cobos and leaks that we were doing on young women is preterm birth and preterm delivery. And there's the odds ratio is greater than 2 to 3 in women who had those leaks. So that was part of the reason also why.
Did everybody hear her in the back? When we freeze or treat a cervix, whether we leap it, we cryo it, we lead to a certain amount of cervical incompetency for future pregnancies. And that's why not only is it cost effective, but it prevents morbidity in women as they progress into their childbearing ages.
Hi, my name is Sarah, and I'm a first-year medical student from Yale. Thanks so much. Thank you so much, Dr. Schur, for your wonderful talk. And I think you're absolutely right that HPV has taken a large step in terms of women's health. But I think given that there's still much unknown out there for the vaccine, that there's work to be done. So I'm wondering how you educate patients on the vaccine efficacy, given that it's less than 100%, as well, given that the serological response, it's still sort of under investigation. And I think you mentioned about patients' risk compensation theory. And a lot of it might not have to do with risk compensation, but rather that the patient's knowledge of how much protection they're getting from the vaccine is not complete. So I'm wondering how you're, I guess, overcoming the gap in knowledge for patients.
I really don't talk about the serological response with my patients personally because we just have limited time to spend with each patient. So I am not worried about the serological response. I think at most we may need a booster shot for people later on. But we have women who are now 6 years ahead of licensing, when the vaccine was licensed, that we can follow. And if there is a drop in coverage, we're going to detect it in those women. We've already demonstrated, too, that this vaccine creates a wonderful amnestic response, so that when people's antibodies do drop and we revaccinate them, it clicks right back up. So I'm not worried about that. I don't talk to the patients. But I think with all messages, we have limited time, but I really, my messages are very simplistic. I think this is a vaccine that works well. It prevents cancers. It does not, I'm very clear it doesn't protect you from acquiring other virus types, and therefore one needs to, continue with safe sexual practices, condoms. This does not protect you against other sexually transmitted infections. So if you make that decision to be sexually active, you need both condoms and hormonal contraception, and you need routine pap smear screening.
So when should the patient renew their vaccine?
Pardon?
When should the patient renew their vaccine?
The series is 0, 2 months, and 6 months. And if they miss the vaccine, you just catch it up whenever they show up in the clinic. But there is no data to suggest anything is needed beyond that. Is that what you're asking?
Yes.
Okay. Thanks. One last
Hello.
question.
Yeah. Hi, my name is Tazeen Rizvi, and I'm a medical graduate. I'll be applying for residency programs now. I really found this session very interesting because of my interest in women healthcare and the preventive measures which can lead to, so that the condition does not occur you do the preventive measures for it. The question that I had was that when you were discussing the side effects of this vaccine, you were saying that syncope was a very prominent phenomena. Is that seen within the first hours when the vaccine has been administered, or is it seen in the coming days or months?
No, syncope is clearly related to the timing of the vaccine. It's seen immediately after the vaccine. The majority of the syncopes occurs with the first vaccination. They didn't see it as much with the second or third, even with among individuals who had syncope with the first one.
All right, thank you.
Thank you.